Cytotoxic is expressed. If you section one of these tumors and you stain it with an antibody NY-ESO-1, you see maybe 20–70% staining at the most of melanoma cells. And so if NY-ESO is heterologically expressed, and T-cell clones specifically target NY-ESO-1, then why do we not see angiologic tumor variants develop, as we did when we gave CD8 positive T-cell clones in our earlier studies? And one possibility may be induction of antigen spreading. And what is antigen spreading? If you give NY-ESO specific T-cells and you kill some of the tumor cells that express NY-ESO-1, they release antigens. Not only the NY-ESO protein is picked up, but all the other tumor-associated proteins can be picked up by these autologous dendritic cells, brought back to the draining lymph node, and then you may induce endogenous response, either CD4 and or CD8 T-cell responses to these non-targeted tumor-associated antigens. These T-cells then fly back to the tumor, hopefully, and eradicate tumor. And so perhaps that's what we're seeing. We looked at responses to other tumor-associated antigens, MART1. We saw an induction of MART1, even though we didn't transfer MART1 responses. We saw induction to MAGE, again, even though we did transfer MAGE-specific responses to induce in these patients. And of course, NY-ESO responses, as we expected to get that MAGE transferred in the patient. Finally, we also looked at GP100, another tumor-associated antigen, and this did not increase after transfer to NY-ESO CD4 T cells, and it turns out the tumor is MART1 positive, MAGE positive, GP100 negative, suggesting that this may be antigen represented. Now, NY-ESO-1 is potentially an antigen associated with tumor melanoma with high replicator potential. I hesitate to say stem cell associated antigens, but some people have called it that, so that may be the other reason why targeting only a heterogeneous population of cells may result in tumor eradication, although that's not been proven either. So the conclusion from this initial study with CD4 T cells is that this is safe. We observe an extended duration of vivo persistence by giving these cells alone. We may have induced antigen spreading that correlated with clinical responses we saw in the other patients, having shown here. There was also increased antigen spreading associated with the partial response to stabilization of disease. CD4 T cells make different cytokines and chemokines, and that profile may be beneficial. We've shown that CD4 T cells can make certain chemokines also migrate to tumor sites and also recruit other effectors. I'm not going to show you that data as well, but if you can select CD4 T cells with a specific chemical profile, you may also attract other T cells and non-specific responders to the area where the tumor is. It's a rational basis with current CD4 and CD8 T cell therapy. You can go CD8 T cells, and therefore why not give both at some point. So that was manipulating one of the intrinsic factors associated with augmenting T cell responses to tumors. The other factor is lymphodepletion, and this can be done with chemotherapy using cytoxin, as we did in the mouse model, or fludarabine, which induces CD4 neutropenia, or even radiation therapy. And the rationale behind doing conditioning is at least threefold, and one is to build a better environment. Essentially, by giving these patients radiation or some type of lymphodepleting therapy, we reduce the lymphocyte pool in these patients. The body responds by upregulating homeostatic cytokines such as IL-15, IL-7, and other growth signals. It also removes the cytokine sink of these other lymphocytes, providing more cytokines to be available for adoptively transferred T cells. And so if you lymphodeplete these patients and then provide them with your antigen-specific T cells, hopefully these will provide increased basal transfer T cells, eliminate suppressor cells or regulatory T cells, and amplify growth factors and promote engrafting of these T cell clones. This is obviously not something I thought of myself, but this is based upon work by many others, both in the mouse model, and this was demonstrated clinically in 2002 by Steve Rosenberg at the NCI, who used tumor-infiltrating lymphocytes which were collected, which basically just a map of lymphocytes of heterogeneous phenotype and specificity from the tumor site, expanded these with high doses of IL-2, 6,000 units per mil IL-2, where we used to be 10 to 50 units at most. And then putting these back into patients, initially didn't see a lot of significant responses that was any greater than giving high dose IL-2. But in this case, when you lymphodepleted patients, you found that these TIL cells survived for long periods of time and induced significant tumor regression. And so the lymphodepleting regimen that he used was high dose cytoxin, 50 milligrams per kilogram for 2 days. So combined with fludarabine, he provides a longer period of CD4 lymphopenia, and then high dose IL-2. Now he had to give high dose IL-2 because this is how the T cells were grown in vitro, and high dose IL-2 in vivo has significant toxicities, including vascular leak syndrome. Patients need to be in ICU type setting because they drop the blood pressure, everything leaks into the lungs. The kidneys damaged, maybe just temporarily, but more than a quarter of the patients were intubated. The other toxicities of this trial I mentioned briefly. However, first of all, he saw dramatic responses in about 50% of the patients, 3 complete responders and 15 partial responders. However, there were serious adverse events associated with this type of therapy, not only due to the high dose IL-2, but due to the complete replacement almost in some of these patients of the T cells that get infused into the patient. And we don't really want that. We want to prevent opportunistic infections from occurring, like PPP, and also EBV transformed lymphoproliferative diseases, which is what happens when you move the T cells from the immune response. Your B cells, which may be affected with EBV, and most of us just grow out of control in polyclonal fashion and develop into tumors. Uveitis, which is where some of these target antigens are shared with some of the normal melanocytes or choroidal melanocytes or uveal melanocytes in the eye, and it can cause inflammation. This can be treated topically or systemically with steroids, but in one patient, he also saw cortical blindness as a result of fludarabine therapy. In spite of the dramatic clinical responses, it can only be used in patients who have accessible tumor and from whom T cells can be generated, and as I mentioned before, which requires high doses of IL-2. So instead of this sort of kitchen sink approach, we decided that we would eliminate fludarabine. We've actually already done a study that was published in PLOS One recently showing that fludarabine induced lymphodepletion does increase the survival of T cells that we give to patients. However, fludarabine is also responsible for a lot of these toxicities when used in combination with cytoxin. Also reverses the Treg, the T effector ratio, and I can talk more about that individually if somebody's interested. So we don't really like fludarabine so much. We did keep the cytoxin because we wanted the lymphodepletion, and we didn't think we needed high dose IL-2 because these cells were grown with vigorous cycles of stimulation in a more physiological fashion requiring low doses of IL-2. And so we gave 14 days of outpatient low dose IL-2 therapy to these patients with progressive metastatic disease, and we didn't use it to antigen-specific T cell clones that could be derived from almost any patients who had the right HLA